Hello future doctors, how are you all? Welcome back to MedSteps YouTube channel. So I'm your Dr. Ananjana. So right now we are doing general surgery series. So today we are going to discuss one of the most common surgical conditions encountered in outpatient clinics and sometimes emergency department in severe cases like strangulation and ward rounds and operating theaters worldwide. So the topic is hernia. So in this video we are going to discuss very basic and advanced about hernia. So let me start with a simple question. Have you ever seen a patient who says, "Doctor, I have a swelling in my groin. It becomes bigger when I cough or lift something heavy like straining activities, and it disappears when I lie down." So what is the diagnosis? The answer is often a hernia. But here is the most important question is, every hernia is harmless? Absolutely not. A simple reducible hernia today can become an obstructed hernia tomorrow and a strangulated hernia the next day, leading to bowel gangrene, perforation and sepsis and even death if not treated on time. So this is why every medical student have to know, if you are doing any general surgery department, you have to must understand hernias thoroughly. So in this master class we will learn what exactly is a hernia, why does a hernia develop, the anatomy of the inguinal canal explained from basic to advanced level, so direct versus indirect inguinal hernia and femoral, umbilical, incisional and other hernias, the clinical examination and asking how to approach OSCE settings and investigations, how to do imaging interpretation and what are the different types of surgeries we have and how to manage. So these are the things. This hernia is very important and these are the main high yield topic frequently asked in FMGE, NEET PG and USMLE exams. So why this video is important? Because by the end of this lecture, you will not only be able to diagnose and manage hernias confidently, but also teach the topic to others like medical doctor. So take your notebook, think like a surgeon and join me as we begin our complete journey from the basics of hernia to consultant level. So let's start with the most important question, that is, what is hernia? So first of all, you can see here, this is the picture. You can, what you are seeing here, if you're focusing on this picture, you can see here one something is protruding outside. That means a hernia is the abdominal protrusion of a viscous or part of a viscous through a normal or abnormal weakness in the wall of its containing cavity. So in simple definition, if any doctor is asking you about this definition, then you have to tell hernia word came by hole plus sac plus content is known as hernia. Because mostly example, if you are saying means, we can see here that is small bowel protruding through a weak abdominal wall. So that is the main like simple definition. Okay, so this is the hernia. So now what are the components we can see in hernia? You can see here, you can see here, these are the components of hernia. So here we have different types of hernia, that is epigastric hernia, ventral hernia, umbilical hernia. Like this we have different types of hernia, but hernia orifice defect, that means first of all the patient will get hernia because of, you are seeing here, right, these are the muscles. So if any patient have muscle weakness in abdominal wall, then the hernial sac, means the peritoneal pouch will happen. So what are the things you can see in hernia means, for example, you are seeing this picture. In this picture you can see like it may contain omentum. Based on the structure site of the hernia, we can see different structures of the gastrointestinal structures. You can see like omentum or small bowel or colon or appendix or bladder or ovary. Okay, so these are the hernia different types of contents we can see. So next we can see here So some little historical background I want to share. So in historical background, you can see here the word of hernia comes from Latin word. From where? It's Latin word. So this Latin word, so the word came by Latin word. So here hernios, that is the Latin word. Hernios means something rupture. So the thing we call hernios. Okay. So the rupture this is we call that is rupture or hernia surgery dates back to ancient Egyptian civilization. So in modern hernia surgery advanced dramatically after, like we have Eduardo Bassani. Bassani, they introduced Bassani repair in 1887. So this is the first surgery we can see in the Bassani introduced that Bassani repair. So that what are the clinical importance? Hernia are the most common surgical disease worldwide, and over 20 million hernia repairs are performed per annum, means annually. So why every surgeon must know hernias? Because hernias may lead to intestinal obstruction and strangulation and bowel gangrene and perforation and sepsis, and some if you miss strangulation, hernia can be fatal. Okay, so that's why this is hernia topic is very high yield important. So next you can see here we will discuss little surgical anatomy. You are seeing here this is we call inguinal regional anatomy. So this is the most important anatomy in general surgery examinations. So you can see here this is inguinal canal. So the inguinal canal approximately we can see 4 centimeters. So the inguinal canal approximately you can see 4 centimeters. 4 centimeters, and it extends from deep ring to superficial ring. So this is the deep ring. We can see here this is deep ring and this is superficial ring. Okay, and we have some boundaries. That boundaries you can see like anterior. In anterior of the inguinal canal, boundaries if you are seeing means anterior, you can see external oblique aponeurosis and internal aponeurosis. Okay, internal oblique muscle. Okay, these are the anterior wall of the inguinal canal. Okay, one is external oblique aponeurosis and internal oblique muscle. So next you can see some posterior wall of inguinal canal. You can see like fascia like transversalis and conjoint tendon. So this is two will comes in posterior wall. If you are seeing in the roof means top, you can see here that is inguinal ligament. Okay, roof will be like inguinal ligament and transversalis transverse aponeurosis you can see. Next you can see here floor. In floor you can see inguinal ligament and lacunar ligament. So these are the main boundaries of inguinal canal. Okay, so this inguinal canal, and if you're seeing means I already mentioned about the deep inguinal ring and superficial inguinal ring. You can see here we have a mnemonic. In deep inguinal ring, this inguinal ring opening in transversalis fascia and is located around 1.25 centimeters above midpoint of inguinal ligament. So if you are saying superficial ring, the superficial ring, the mnemonic will be like exit. The deep inguinal ring will be like entry of for that hernia sac and content, and the superficial ring will be like external exit. Okay, so you can see here that is like in superficial ring you can see triangular defect in external oblique aponeurosis. Okay, so in deep ring we can see some structure that is transversalis fascia, inferior epigastric vessels, medial to inferior to we can see medial. So you can see medial epigastric arteries, and inferior means you have to suspect the patient that this deep inguinal ring. And then after in T we can see transversus abdominalis and inguinal ligament. Okay, so if you're seeing deep ring, the layer will be like fascia and lateral to vessels. Okay, so this is indirect hernia. If you're seeing superficial ring, from superficial ring, if you're seeing like that is oblique, TLC means tubercle, pubic tubercle, and you can see ligament in pubic crest, and you can see crura, medial and lateral. So if you know this anatomy, you can easily do physical examination, and you can do that special test in physical examination of hernia. Okay, so that's why this anatomy is very important in hernia topic, because in ASCII settings the doctor can ask this type of questions. Okay, if anything directly without entering into deep ring, if it's coming means that is direct hernia. With deep ring, if anything coming means we have to suspect the patient have like the patient have indirect hernia. Okay, so these are the things. Next we can see here, this is very important triangle, that is Hasselbalch's triangle. This is the most frequently tested anatomy, and we can see some boundaries here. This is the boundaries, is very important, like a triangle shape. You can see these boundaries. In medial side you can see rectus abdominis, this muscle, and in lateral you can see the blood vessels are going up, so that we call inferior epigastric vessels. In inferior we can see inguinal ligament. So medial will be like rectus abdominis, and lateral will be like inferior epigastric vessels, and inferior will be like we can see inguinal ligaments. Next we can see direct hernia occurs here, that is common Viva questions the doctor can ask about the direct hernia. Okay, so same to same, this is also Hasselbalch triangle. Next we can see here, that is spermatic cord contents. This is very important. We have one mnemonic, that mnemonic we called MDVAN, MD van. Van means always we have to remember vas deferens, artery and nerves. Okay, we can call rule of 3, means 3 arteries, 3 veins, 3 nerves. Okay, and you can see that lymph nodes and everything. So MD van means vas deferens, you can see, and arteries and nerves. Next, blood supply. In blood supply you can see the spermatic cord. The spermatic cord contains, you can see, blood supply is like inferior epigastric arteries is the key landmark, and it will help to differentiate direct versus indirect hernia. Next you can see here, that is embryology. In embryology you can see processes vaginalis, that during fetal life, and peritoneum descends with testis and normally obliterates failure to. If failure means, then patient will get indirect hernia because of process of vaginalis, weakness in if patient have weakness in abdominal content, you can see that is direct hernia. Next, in clinical correlation, patent process vaginalis is indirect hernia, and it can cause hydrocele and congenital hernia. So important surgical marks, because for surgeries the landmark is very important. So deep ring, superficial ring, inferior epigastric vessels, and pubic tubercle and inguinal ligament. So these are the main things. So during surgery, what are the structures can have like highest risk? We can see like vas deferens, okay, and testicular vessels. Next we can see ilio-inguinal nerve and ilio-hypogastric nerve, and genital branch of genitofemoral nerve. Okay, so these are the main common injured structures. Okay, so these are the things. Next we can see here, in hernia we already discussed, that is deafness and protrusion of viscus, a part of viscus through the wall of its containing cavity. So this compromises of hernial sac and neck. So we can simply tell that is abnormal opening, may be artificial or natural. So if patient have any area of weakness and disruption of the fibromuscular tissue of the body wall, you can see here, this is the best example and best image, you can appreciate very easily. Here the patient have muscle weakness, because of the abdominal hernia content protruding outside. Okay, so these are the things. Now you can see here what are things happening in this picture. In this picture, if you're seeing here, for example, I'm zooming. Okay, so if you're seeing this picture, you can see this is if you're seeing physiology, normal function of abdominal wall. What function it will do? It will provide protection, support, and pressure generation. So normally we have some pressure we called intra-abdominal pressure. So normally it's controlled by muscle and fascia and connective tissue. So what prevents hernias means certain mechanism like internal oblique contracts and the canal will close. And we have another one ball valve mechanism, that is raised pressure and it will compress the cord ring, then after it will prevent protrusion. Okay, so these are the things. Next you can see hernias. We have different types of hernias. So first one, uncle hernia, we can see after head injury. Next we can see internal hernia, the muscle through its facial covering. And we can see external hernia, we can see weak normal opening like inguinal and femoral hernia. Next we can see incisional hernia, we can see abnormal opening. So 75 to 85% of abdominal wall hernias are grown hernias, and 15% of male hernias we can see it will develop grown and hernia. 5% of grown hernia we can see in females. Okay, so we have different types of hernias I told, right? So first of all we have some inguinal hernia, that is the most common type of hernia, that is 73% you can see. Then after inguinal region is weak and it will the natural weakness like deep ring and cord structures, then it will cause inguinal hernia. Next we can see femoral hernia like 17%, umbilical hernia will be like 8.5%, and excluding incisional hernia we can see 1.5 percentage. Okay, so now we can see here some etiology, means causes of hernia. You can see here this is the causes of hernia. We have two different types of causes of hernia. One is congenital and acquired. So in congenital we can see that is because of patent process vaginalis. This is the most common cause of indirect hernia. So the most common will be like performed sac defect, and it's present in later period, and it causes like indirect inguinal hernia. Next we can see acquired causes, means secondary to some other causes, any causes like with increasing abdominal pressure and leading to weakening of the area like a direct inguinal hernia. Okay, so what are the things will cause this in acquired hernia? What are the things will cause means, first of all you can see here increasing intra-abdominal pressure. So what are the things will increase abdominal pressure means straining activities, means lifting too much heavy weights, lifting of heavy objects, weights, and chronic constipation like habitual or rectal strictures, and chronic cough. In chronic cough, what are the pathological conditions you can see like tuberculosis, chronic bronchiolitis, bronchial asthma, and emphysema. So these are the things can be like risk factors or causes of acquired causes. Next we can see urinary causes like old age, benign prostate hyperplasia, carcinoma, and prostate, and young age like you can see stricture and urethra, and very young age like phimosis and meatal stenosis. So these are the things and will cause increasing abdominal pressure, and the patient we can see this, and obesity also can cause increase intra-abdominal pressure. Okay, and we have some connective tissue disorders like Ehlers-Danlos syndrome and Marfan syndrome can cause muscle weakness, and it will cause hernia. So next we can see some weakness, wall weakness. In wall weakness mostly we can see ascites. Whenever the patient have ascites, the fluid will stretch the abdominal wall, then the patient will get very prone to get wall weakness in abdominal wall, and the patient will get hernia also. Next we can see obesity and pregnancy females, and pelvic anatomy like femoral hernia is common because of getting more multiple parity. Next smoking and malnutrition and aging is the one of the factor. Next we can see previous surgeries like appendectomy through the McBurney incision, and it may injure the ilioinguinal nerve, and it causes right-sided direct inguinal hernia. Okay, and female means we can see collagen disorder and like prone belly syndrome, and we can see acquired herniation like collagen deficiency called metastatic emphysema. Okay, so the main risk factors we can see like smoking. So the smoking will weak smoking. The main mechanism is the smoking will weak the collagen. Next, obesity. Obesity will increase. Um, yeah, it will increase abdominal pressure, and we can see COPD, chronic obstructive pulmonary disorder, like it will cause chronic cough. Next we can see constipation. Constipation will act like it will cause straining activity. Next one we can see pregnancy. So um, the pregnancy will cause a pressure increases. Okay, so these are the things. So what are things will happen in hernia means we have to understand the pathogenesis of hernia. Whenever patient getting any weak abdominal muscle, so it will increase the we can in body we can see it will the intra abdominal pressure will rise, then progressively the facial will become weak, then peritoneal will get protrusion, then after this the because wherever the patient have the peritoneum, the abdominal wall have weak spot, that weak spot we can see sac formation, then after we can see visceral herniation, the content will come out, the structures will come out, then after we can see reducible hernia means and irreducibility and obstruction and strangulation. These are the things we can see in pathogenesis of hernia. In cellular mechanism, if you are seeing means abnormal collagen metabolism because of smoking patient, we can see reduced type 1 collagen. Because of reducing type 1 collagen, the fascia will become weak, and we can see hernia formation. So next we can see here that is pathology. In pathology we can see some components like sac, peritoneal sac, and the neck will be like opening, and we can see body, that is main sac, and we can see some contents, that is bowel omentum. Okay, so here as we discussed before, that is we have some different types of hernias. That is we can divide this types of hernia into two different parts. One is external hernias and internal hernias. In external hernias we can see inguinal, femoral and umbilical and epigastric, incisional and spigelian and lumbar hernias. Next we can see internal hernias, that is paraduodenal, mesenteric, foramen of Winslow hernias. Okay, so we have some classification of reducibility. So before that we have to understand the parts of hernias and how it will comprises of the structures, how it will compromise. So here we can see covering. So the layers of abdominal wall through which the sac passes. So the coverings will be part of hernias. Next we can see sac. In this sac we can see like diverticulum of peritoneum with mouth, neck, body and fundus. Next we can see neck is narrow in indirect sac and wide in direct sac, and body of sacs in thin and in infants. So we can see some contents, that is first one omentum and ometocele. If the patient getting difficult to reduce the sac later and reduced easily, then we have to suspect the patient the content will be like omentum or omentocele. Next we can see enterocele. Enterocele means like small bowel, and sometimes we can see large bowel also. Next we have another different types of hernia, that is hernia contents, that is Richter's hernia. Richter's hernia means portion of circumference of bowel is the content. Next we can see cytocele. Cytocele means it may be urinary bladder, may be the content, or part of the posterior wall of the sac. Next we can see like ovary, often with fallopian tube. Next one Meckel's diverticulum. The Meckel's diverticulum we call Richter's hernia. Next we can see Amian hernia, that is inguinal hernia, contains verniform appendix. Means the appendix we can see in Amian hernia. Okay. Next we can see D. Garangiot hernia, that is femoral hernia, contains appendix. Okay, so we have total we have one classification based on easily we can remember this classification based on clinically according to cause like etiology, according to contents and anatomical classification. So first one we are seeing here, that is clinical class. So clinical classification we can see like reducible hernia, irreducible hernia and inflamed hernia. So if you are seeing here, that is reducibility classification. In clinical classification you can see reducible hernia. So here reducible means the contents will return to the abdomen, so that thing we call reducible hernia. Then after we can see irreducible hernia, also known as incarcerated. So this incarcerated is can't be reduced. So in irreducible hernia we can see obstructed hernia. Obstructed hernia means we can see bowel obstruction present. And next we can see strangulation hernia, that is blood supply will be like compromised, and we can see it's like most dangerous, okay, because it will be become life threatening. So next we can see that is inflamed hernia. Okay, so first one, reducible hernia. Here we can see, I already mentioned, it will reduce by own, or patient or the doctor will try to reduce the thing manually. Then after, if it's not working, then we have to go with surgery. Next, intestine reduces with gurgling and difficult to reduce the first portion. Next we can see momentum is doubling and difficult to reduce last portion, and we can see expansile, impulse and cuffing present. Next we can see here, that is irreducible incalcinated hernia. It can't be reduced, return to abdomen, narrow in like neck adhesions and overcrowding like predisposes to the strangulation. Next we can see obstructed hernia, that is irreducible hernia with the bowel inside that is obstructed but blood supply is not interfered. Next we can see strangulation hernia, that is irreducible hernia with obstruction to blood flow, and we can see swelling like tense, tender with no impulse and cuffing, and with features of intestinal obstruction, and this intestinal obstruction will cause omentocele, Richer's hernia and Letter's hernia. It may be absent in such cases. Next we have inflamed hernia, that is inflammation content of the sac, example appendicitis and salpingitis. The hernia is the tender but not tense. So this overlying skin is red and edematous. Okay, so these are the things. So next we can see some clinical features, that is mostly we can see symptoms, that is groin swelling. So this is the most common symptom. So the swelling, mostly we can see the swelling will appears on patients when patient standing, coughing and straining. Okay, so when the swelling will disappear when patient is lying down and reduction. Okay, so these are the things. So intermittently we can see based on movements it will reduce and it will increase, or constant, or increased on standing and or coughing. Next we can see reducibility, can be pushed back in early stages. Next we can see cuff impulse. In cuff impulse the swelling will increase when cuffing. Next we can see pain, usually dull ache and worse with exertion, and we can see some obstruction, strangulation and painful like irreducible vomiting, distension and emergency. Okay, so for example I will give one clinical presentation, because in general surgery department in ASCII sessions the doctor can ask this type of Viva questions. So for example, a 55 years old man notices swelling in groin that appears on cuffing and disappears when lying down. So the diagnosis will be like the patient is telling groin region swelling is there, that means inguinal hernia. So in signs you can say like while doing physical examination you can see that in inspection we have to look for groin swelling and cuff impulse and size. Next, whenever you are doing palpation, that time we have to assess reducibility, tenderness and expansile cuff impulse. Next we can see some red flag signs, that is severe pain, irreducibility, vomiting, abdominal tenderness, tachycardia. Whenever patient getting this type of red flag signs, we have to suspect patient have strangulated hernia. So whenever patients coming to the hospital, we have to do proper assessment, right? In that assessment we will take history. So in history taking we have to ask some very important questions we have to ask, because if you are in general surgery department in ASCII setting, the doctor can ask the doctor have some checklist. In the checklist they will mark, so you have to complete this every questions we have to ask to the patient while taking history taking. So what are the questions we have to ask? When first noticed the swelling, then after the swelling getting pain, it's gradually it's increasing size or same to same like similar. Next one, it's reducible or non-reducible. Next, patient have any vomitings, any history of constipation, any previous surgery, because incisional hernia also we can see, that's why we have to ask previous surgery, or chronic cough, or patient have any smoking. So if the examiner asking you, just tell me the most common hernia, that is indirect inguinal hernia. This is the most common hernia. So most dangerous hernia is, that is femoral hernia. Okay, so in physical examination we have to do inspection while standing, like sight, shape of hernia and size. Next we have to check with the cuff impulse test. We have to ask patient to cuff. If patient while cuffing, if patient getting like expansile swelling, then the test will be like positive. And reducibility, gentle reduction. Next we can say deep ring occlusion test, that is reduced hernia. Next we can see compress deep ring. We have to ask patient to cuff. If swelling is prevented, then that is indirect hernia. So next we can see invagination test, like we have to keep our finger into the scrotum and we have to assess posterior wall, use it to differentiate hernias. Okay, so these are the things. Next we can see here, that is these are things very important, that's why I'm writing here. That is, one is differential diagnosis. So whenever any doctor is asking you differential diagnosis, that is first one hernia. Okay, so next we can see, that is hydrocele. Next we can see varicocele. Next we can see, that is lymphadenopathy. Next, if child means, we have to mention undescended testis. Next we can see femoral aneurysm. Okay, so hernia. In hernia we can see patient will the cuff impulse will be like positive. In hydrocele, the trans illumination test will be like positive. In varicocele, when you are palpating, that time you can feel bag of worms type of palpation. In lymphadenopathy, we can see film nodes. Next, if you are suspecting like undescended testis, we can see empty scrotum because we can't palpate the testis. Next, femoral aneurysm means we can see the key features will be like pulsatile. Okay, so next, how to do investigation in hernia. So in investigation, the clinical diagnosis is first. Okay, so most hernias requires no investigation. So history taking, then after mainstay, then after inspection, palpation and cuff impulse we have to do. Then after we can go with ultrasound, because this is the first line imaging. This is useful for occult and incisional hernia. Like ultrasound we are using for mostly small hernias, obese patients and occult hernias. Next we can go with CT scan. This is the best for complex hernias, internal hernias and recurrent hernias. So most accurate for deep hernias or complications. Next we can do like X-ray. In X-ray abdomen, if observation suspected, then you have to do X-ray abdomen. Then after we can go with MRI, that is highest sensitive for occult grown hernias. In MRI, especially for pelvic obstructed hernia or recurrent cases. So in image interpretation, if in ultrasound we have to check with hernial sac, bowel movements and defect visualized. In CT findings, we have to the CT finding will show like a neck and what are the sac and what are the contents present inside that hernia and complications. So next we have some classification. So based on the classification, we have to treat the hernia patients. First one inguinal hernia, that is we can see indirect and direct. So indirect hernia will be like lateral to the inferior epigastric vessels through deep ring. This is the most common. Next we can see direct indirect hernia, that is medial to inferior epigastric vessels through Hasselbalch's triangle. So for doing surgery in GPHC, we are following one method, one classification, that is NEET classification. Okay, this NEET classification is widely used in advanced surgeries. Okay, so these are the things. Now management. So in management, patient have all symptomatic hernias should be repaired unless contraindicated. Why? Because every hernia carries a risk of incarceration, obstruction and strangulation, bowel ischemia and death. So that's why it's like we have to do proper management for hernia. So treatment decisions based on chart. For example, if patient have reduced hernia, we have to do elective surgery, mesh repair preferred, and irreducible hernia means we have to do urgent evaluation, possible surgery, strangulation hernia and emergency surgery. So the main goal is to return contents to abdomen and remove or reduce sag and the closed defect and reinforce abdominal wall, and we have to prevent recurrence. So next we can see here, that is management. In management we can see conservative management. When can we observe? Only in selected patients, for example like very elderly patient and severe comorbidities like heart problems, diabetes, hypertension, hyperlipidemia. These are things will come in severe comorbidities and high anesthetic risk and minimally symptomatic hernia. So we can see what we have to appropriate mainly for small minimally symptomatic inguinal hernia means this is not appropriate for femoral hernia, strangulated hernia and obstructed hernia. So in conservative management we can use supportive truss. It's like rarely nowadays it's using, very rarely nowadays it's using. So the historically used for like hernia truss, currently rarely recommended because the problem says it does not cure hernia and patient will get skin complications and false reassurance we were giving, that's why. So we have to do risk factor modification. We have to treat chronic cough, constipation, obesity and smoking. So in surgical management, when we have to do surgeries, if patient have like strangulation, obstruction or femoral hernia or progressively enlarged hernia, or relatively like patient getting lifestyle limitations or pain or cosmetic concerns or occupation related issues, we have to do surgery. So when we can't do surgery means uncontrolled sepsis, severe cardiopulmonary instability means we can't do any surgery. So we have to do pre-operative preparation, history taking, physical examination, consent and anesthesia assessment, labs, imaging if needed. Then after we have to types of repair like tissue repairs. In normally we can tissue repairs means we have like no mesh used, that is examples like bassining and solders. In mesh repairs we are using gold standard, that is Liechtenstein tension free repair and the tap and tap. So this mesh advantages, why this mesh is important? This mesh advantages will be like lower recurrence, less tension and better outcomes. So first of all we are going to discuss about this Liechtenstein repair. So this is a gold standard open repair, most important operation for exams. So in indications we can see primary inguinal hernia, mostly adult patients we can do this surgery. We have to give proper patient position like supine position. Then after we have to, the anesthesia have to give like local spinal general anesthesia based on patient age and conditions. Next we have to do incision oblique to the inguinal incision parallel to the inguinal ligament, oblique to the inguinal incision and parallel to the inguinal ligament. Then after we have to do skin incision, skin incision like assess the main purpose why we have to do skin incision means for assessing inguinal canal, and the structure while doing that incision the superficial vessels will be like disc. Okay. Then after we have to open external oblique, like we have to expose the canal. Then after we have to structures ilio-inguinal now will become damaged, so we have to be careful. Then after we have to mobilize spermatic cord, we have to identify cord structures like structures at risk, vas deferens and testicular vessels. Then after we have to identify the hernia sac, we have to determine direct or indirect. Then after we have to do sac management like we have to dissect or we have to ligate or we have to excise. So indirect hernia means we have to reduce the sac and we have to repair posterior wall. Then after we have to do mesh placement. Mostly the mesh made by polypropylene mesh placed over the posterior wall. Then after the main purpose is tension free reinforcement. Next we have to do mesh fixation to pubic tubercle, inguinal ligament and conjoint tendon. Then after we have to create a mesh slit. It's like it will accommodate spermatic cord. Then after we have to close the external oblique and the subcutaneous tissue and skin. So always identify nerves before mesh fixation. So next we can see that is shoulders repair. We can see in herniorrhaphy. In herniorrhaphy we have two different types. We already discussed, that is repairing of defect like tissue repair. So we have bassini and shoulders. Now we are discussing about shoulders repair. So most successfully non-mesh repair, that is uses multi-layer reconstruction of posterior wall, and it's used when mesh contraindicated. Next we can see bassini. Bassini means it's historical operation. We discussed about this bassini in historical background. In 1889, the bassini first they started this surgery and everything. So that's why we the name also bassini repair. So in bassini repair, what they are going to do? They are suture the conjoint tendon sutured to inguinal ligament. But this bassini repair have higher recurrence than mesh repair. So next we can see laparoscopic repairs. That is two major techniques we have in laparoscopic. Sorry, I forget to mention about herniotomy. Herniotomy is mostly we are doing on children. Okay, we are removing the hernia sac, that is herniotomy. Next we can see here laparoscopic repairs. We have two different types of laparoscopic repairs. That is first one TAP. TAP means trans-abdominal pre-peritoneum. So this trans-abdominal pre-peritoneal repair, we can see it will enter the peritoneal cavity. Then after it plays mesh pre-peritoneally, and we can see some advantages, that is like bilateral hernia, recurrent hernias and less pain. So these are the TAP advantages. Next we can see TEP means total extra peritoneal. So totally extra peritoneal repair, we can see no entry into the peritoneal cavity, preferred laparoscopic method. So in advantages we can see less bowel injury risk and less adhesion formation. So next we can see femoral hernia repair. Most important fact is highest strangulation risk is femoral hernia. So we can go approach with like Lockwood, Lothesian and McEvedy. So McEvedy approach will be like preferred in strangulation femoral hernia. It provides abdominal access. So next we have umbilical hernia repair, that is small defect primary close. We have to do small defect. So we have to do primary closure, and we have to large defect means we have to place mesh and we have to repair. Next incisional hernia repair, how to do means common after laparotomy. The risk factors will be like infection, obesity and smoking. The treatment will be like mesh repair, and component will be like separation, and abdominal wall will be like reconstruction. If any patient came with strangulation hernia, we have to do emergency operation like steps, open sac, assess bowel viability. Then after we have to resect non-viable bowel, and we have to do anastomosis, and we have to repair hernia. So how to check that bowel viability assessment means healthy bowel will look like pink, peristalsis will be present and mesenteric pulsation will be present. The dead bowel will be like we can say black and no pulsation, no peristalsis, and it requires resection. Okay, so In laparoscopic hernia repair will be like we have some advantages, that is less pain, quick recovery and better cosmetics. Next we can see preferred for bilateral hernias, recurrent hernias and young, active and individualization. Next we can compare that open versus laparoscopy. In open surgery, anesthesia will be like we have to give local or spinal. In laparoscopic repair we have to do general hernia, general anesthesia. Next, the recovery will be like slow in open repair because of big incision. The laparoscopy will be like fast recovery. Next, we can see recurrent rate will be like low in open repair. In laparoscopic will be like lower and similar. Next, cosmesis we can see scar. In laparoscopic we can see minimal scars. Next, we can see the pain will be like more in open hernia, Herniorrhaphy or hernioplasty. In laparoscopic will be like less pain. The cost will be like cheaper in open repair, and the laparoscopy cost will be like the cost will be like more. Okay, we can see some complications in patients with if the doctor is asking tell me the complications in patient with hernia means we have to divide the complications into 3 different parts. One is intraoperative. Next we can see early operative. Next we can see late operative. Okay, so in intraoperative we can see like bleeding and the surrounding structures will become injury, so bowel injury, and we can see bladder injury. Next we can see vascular injury. Next we can see nerve injury. So these are the main intraoperative complications. Next we can see early post-operative complications, that is the patient can get hematoma, seroma, wound infection, urinary retention, scrotal swelling. Okay, hematoma, seroma, wound infection and urinary retention and scrotal swelling we can see. Next, late post-operative complications we can see like patient can get recurrence, chronic groin pain. Next we can see the mesh infection or adhesions. Next, patient can get testicular atrophy. Next, if any nerve trapping into mesh, the patient can get neuralgia. Okay, sometimes we can see life-threatening complications, that is missed strangulation and bowel necrosis and sepsis and perforation. And how to prevent the thing, we have to do tension-free repair, proper mesh placement, and we have to avoid nerve injuries and meticulous hemostasis. Okay, if patient coming with strangulation hernia, we have to go with surgical emergency management. That is initial approach like A, B, C, D, E, like airway, breathing, circulation, disability and exposure. We have to give intravenous access and we have to give fluids, analgesia and antibiotics and nasogastric tube and catheter. Never force reduction because the reduction en masse means gangrenous bowel may remain trapped. Okay, so the recent guidelines is telling like mesh repair for most adults. If patient is adult means mesh repair is the best surgery, means like hernioplasty. Next one you can see the current recommendations is mainly favor on laparoscopic repair for bilateral hernias, the laparoscopic repair for recurrent hernias, and we can see early mobilization and day care surgery when possible. Okay, so these are the things. So mostly we covered everything. In the last, I want to give one clinical vignette, like a clinical station scenario. Like 55 years old man. Actually, when I'm doing general surgery department, that time I saw this case in accidental emergency department. Okay, so when I'm doing on call, that time I saw this patient. Like patient have 55 years old man, right groin swelling, and it increases on coughing, and you can see reducible. So I took that history and examination and diagnosis, and the doctor asked management plan. So the expected diagnosis will be like right indirect inguinal hernia. So management, as I told you before, is reducible. So I told him to do conservative management. So like that, the doctor can ask some questions. So we have to tell properly. Okay. So these are the things. Mostly I covered everything about this hernia, that are basic to advanced, the surgeries and everything. If you have any doubt, you can ask me in comment section. If you didn't subscribe my channel, like, share and subscribe. And along with that, right now I'm signing off. In general surgery, this series I already uploaded about appendicitis and thyroid and cellulitis and abdominal trauma and hemorrhoids. So if you have any doubt, or if you want to discuss any other topic, you can message me in Telegram or Instagram or comment section. Okay, so I'm signing off. We will meet you in our next video. Till that time, take care.